Welcome to the presentation on preventing venous thromboembolism, abbreviated as VTE, in stroke patients. My name is Deidre De Silva, and together with advanced practice nurse Irene Sin, we will discuss the rationale and strategies for prevention of VTE in ischemic and hemorrhagic stroke patients. At the end of this presentation, you should understand the impact of VTE on stroke patients, and thus the reasons we need to prevent it, and you should also know the evidence-based strategies for VTE prevention in stroke.
Venous thrombosis is the formation of a blood clot in a vein. This often manifests as deep vein thrombosis, abbreviated as DVT, affecting the lower limb, typically in the thigh or calf. If the clot in the vein breaks off as an emboli, it can travel to the lungs, causing pulmonary embolism, abbreviated as PE. The disease process that encompasses DVT and PE collectively is known as venous thromboembolism VTE. Virchow-Triad explains the development of thrombosis as an interplay between venous stasis, blood vessel injury, and hypercoagulability. VTE is a common complication in stroke patients, with the incidence reported as between 10 to 50%. VTE has serious consequences. DVT can be complicated by post-thrombotic syndrome. These patients experience chronic and persistent pain and swelling. Approximately 30% of the patients who have had the DVT will suffer a PE. In about one-third of these patients, it is fatal. Pulmonary hypertension may develop in some patients who survive their PE. There are also financial costs associated with the treatment of VTE in post-stroke patients. Therefore, it is very important to strive to prevent VTE in stroke patients. We have categorized the strategies for VTE prophylaxis into general measures, pharmacological prophylaxis, and mechanical means. General measures for VTE prophylaxis in stroke patients include early mobilization, leg exercises, and maintaining good hydration. These are often neglected, yet can play an important role in adjuncts to mechanical and pharmacological methods of VTE prophylaxis.
Pharmacological VTE prophylaxis is via anticoagulants, namely unfractionated heparin and more commonly low molecular weight heparin. The PREVAIL study, an open-label randomized trial, compared the efficacy and safety of low molecular weight enoxaparin with that of unfractionated heparin for patients with ischemic stroke. Enoxaparin reduced VTE risk with similar risk of bleeding, leading to the conclusion that enoxaparin is preferable to unfractionated heparin in preventing VTE in patients with ischemic stroke. In a trial comparing low molecular weight heparin to thigh-high compression stockings after the first 48 hours of a hemorrhagic stroke, there was no enlargement of the intracranial hemorrhage with low molecular weight heparin. There are some considerations with use of anticoagulation for VTE prophylaxis in stroke. Anticoagulants are contraindicated in the first 24 hours after thrombolysis treatment. There's also relative contraindication when there's significant hemorrhagic conversion and concern of hematoma expansion in hemorrhagic stroke. In summary, for ischemic stroke, low molecular weight heparin is more effective than unfractionated heparin and is relatively safe. For hemorrhagic stroke, there's limited efficacy data, but it does appear to be safe.
We now move on to discuss mechanical prophylaxis for VTE in stroke patients. Mechanical prophylaxis of VTE encompass local devices which mitigate venous stasis in the deep leg veins and increase venous blood flow velocity. The commonly used methods include graduated compression stockings, abbreviated as GCS, and intermittent pneumatic compression or IPC devices. A series of 3 studies evaluated the mechanical interventions. The CLOT-1 studies evaluated the effectiveness of compression stockings. The CLOT-2 study compared thigh-high and knee-high stockings. Finally, the CLOT-3 study looked at the effectiveness of intermittent pneumatic compression devices in immobilized stroke patients. IPC device use a pneumatic pump to compress calf veins through the intermittent inflation of sleeves wrapped around the lower limbs. They act to recreate the pulsatile deep venous flow usually created by ambulation, preventing venous stasis. The CLOTS 3 study compared two groups. One group had IPC and the other did not. IPC use was associated with a lower incidence of proximal DVT and a lower risk of mortality at 6 months. There was, however, a slightly higher risk of skin breaks with the use of IPC. This trial changed the landscape of VTE prophylaxis in stroke, providing clear evidence for the use of mechanical prophylaxis with IPC devices.
Another form of mechanical prophylaxis is graduated compression stockings, abbreviated as GCS. These are available in thigh and knee-high lengths. Guidelines advise against the use of GCS for VTE prophylaxis in stroke patients. In the next few slides, we will show you why we should not use GCS after stroke. The CLOTS 1 study, a large multi-center randomized trial of GCS in stroke patients, compared thigh-high compression stockings to no GCS. It showed that thigh-high stockings did not reduce VTE events. There was also a significantly higher incidence of skin complications. The CLOTS 2 study compared thigh-high to knee-high stockings in patients with acute stroke and found less proximal DVT in the use of thigh-high stockings. However, skin problems were more common among patients who received thigh-high stockings. But as seen in the earlier slide, thigh-high stockings did not reduce VTE. Therefore, there's no evidence for the efficacy of GCS for VTE prophylaxis in stroke, and in fact, they have been shown to cause skin complications. In summary, there's no role for the use of GCS for VTE prophylaxis in stroke patients. IPC devices are effective in reducing VTE in stroke patients. Of note, there has been no head-to-head study comparing IPC devices versus subcutaneous low molecular weight heparin or any study investigating the combination of subcutaneous low molecular weight heparin with concomitant mechanical means. The take-home messages for this presentation are: VTE is common, has serious consequences, and is largely preventable. Thus, VTE prophylaxis is standard of care, and we all play an important role in ensuring that they are implemented in stroke patients with limited mobility. It is important to note that limited mobility may be due not just to limb weakness, but other neurological deficits such as ataxia and visual impairment, as well as orders for bed rest by the medical team. There are three main strategies for VTE prophylaxis in stroke. Importantly, we must not forget general measures of early mobilization, leg exercises, and good hydration. These should be implemented in conjunction with either mechanical or pharmacological measures. Subcutaneous low molecular weight heparin is also effective, but there are concerns of bleeding risk. IPC devices are effective for both ischemic and hemorrhagic stroke. Thank you for your attention, and we hope that you now have a better understanding of VTE prophylaxis for stroke patients.